Dr. Hartman, great to have you back. Welcome.
It's great you're back. I'm super excited to have a conversation today.
Absolutely. What do you think is the single biggest structural flaw that you see in traditional allopathic medicine? And how has your practice model kind of evolved over the last 20 plus years in response to your experiences, both personally and professionally?
That is a big question. The biggest structural flaw, it's part of our strength is our weakness. And it's just, we have this amazing educational system. In the United States, you do 4 years of undergraduate, 4 years of medical school, 3 to 7 years of residency. So you get this massive knowledge base when you get out of school. But the way it's set up, it's almost like you've arrived at the pinnacle. And it's almost as if, at least in medicine many times, that once you get there, the curiosity, the hunger for new knowledge, it's not perpetuated. So what happens is you get your board certification, you get your thing, and it's like, I finally reached the pinnacle. I'm a board certified XYZ. And it's like, the reality is, no, you've just got the ticket to show up. Mm-hmm. Congratulations, insurance pays for your time now. And we get in these silos. And it's partly because of that whole educational system that I was literally forced out of against my own will, not by my own volition. And so that's part of the reason why people jump from specialist to specialist, doctor to doctor, because once you get in your narrow pathways, we lose the ability to have that vision around us. In medical school, we did biochemistry. Mm-hmm. And I was told in medical school, you'll never use this again. You're just doing biochemistry so you can pass your boards. Like half of functional medicine is biochemistry, genetics, cell biology. And so it's interesting how something that was a throwaway in medical school is a standard in the functional medicine world. So I think that's that educational, like our strength is our weakness. And just realizing once you get to a certain pinnacle, it's like now true education begins because they have the tools to build on. And that's not something that people leave their graduate level education with.
Well, I think it's so interesting because I reflect back on, 20 years in a traditional model, first in ER medicine, then cardiology, and how frustrated I felt and constrained with the model where I was effectively told, if this doesn't fall into the cardiology bucket, you refer them to a specialist, you refer them back to internal medicine 9 times out of 10. I was told to stay in my lane. And yet, we're complex organisms. One system of the body it absolutely integrates with other systems of the body. And to somehow suggest that if you are a gastroenterologist, you only worry about GI issues, or if you're a cardiologist, you only worry about cardiology issues, or if you're in internal medicine or family medicine, you have to worry about everything, is in many instances, I think that your points about the siloed part of medicine combined with rigid dogmatism of, okay, I studied in the 1990s, that's when I trained, therefore everything I learned is all that I need to learn, and I don't need to continue learning. And one thing that was really kind of invested in us in where I went to graduate school was that you are a lifelong learner. You are expected to evolve, shift, and change. And so help my listeners understand, what was it that happened with your daughter? You have this extraordinary family. You and your wife are just incredible individuals, and your children are also incredible. What was it about Anna's story for you and advocacy of her care that really was the catalyst to opening up your perspectives about the limitations of this traditional model?
It was basically out of desperation. It was nothing I chose. That's kind of like what was given to me. So my wife is a pediatric occupational therapist, and Anna was one of her therapists, always one of her patients, sorry. And her foster home was closing down. And so Becky asked me, hey, would you want to bring Anna in, foster her? And so my thinking, and you kind of know me, I was like, our first question to Becky was, can we give her back? And Becky was like, being a loving wife, knowing that I would eventually fall in love with Anna. She's like, sure. And so we brought her in, and I really fell in love with this gorgeous little girl. But part of it was her feeding. So kids with cerebral palsy or have low amounts of body weight, failure to thrive was a big thing. And so we worked on feeding her. I remember flying food into her mouth. My wife and I debate, how much of that I did, but I vividly remember that. But she was still failure to thrive. She was still less than the 5th percentile. So the GI doctor was like, we're going to do the next standard thing, which is standard protocol all these kids get, is a feeding tube. We're going to cut a hole in her belly, place a plastic tube in so we can pour formula and put weight on her. They didn't care if it was fat, muscle, whatever, just put some weight on her. And from talking with Becky, her specialty, one of her specialties was feeding, handwriting, all these fine, as an occupational therapist, a lot of that kind of stuff. And the goal is that she's going to talk, even though specialists said she'll never be able to talk in her life because her brain damage was so significant. Part of learning how to talk is chewing and swallowing. It's critical for speech development. Part of learning to walk is you crawl. Well, it's kind of hard to army crawl when you have a plastic tube coming out of your belly. So me just being like, I had goals and dreams and visions that she's going to do these things, regardless of what. At that point in time, I wasn't thinking that clearly. Like, this is what she's going to do, right? And so we opted not to do that. And this was, I talk about 2 inflection points in my book. The first inflection point was the result, what happened when I said no. And the result was my wife and I were reported to Child Protective Services for child neglect because we refused to follow the doctor's orders. We chose to give her real food, not processed food, not do a surgical procedure. Now, because we were already in the system, I was a captain in the Air Force, we were able to navigate that. But most parents, most families, most foster families don't, and the kid gets a tube and their trajectory is changed forever. So I wasn't thinking that. I was thinking feeding her and getting her, trying to do balancing and all that kind of stuff you do with a kid with a significant brain injury. But the other inflection point that became my weight, became my burden, became my duty. I don't know if these are the right words to use, but 6 months later, Becky found a growth chart for kids with cerebral palsy, which is the diagnosis Anna has. And she was 50th percentile. So she was normal. The specialist had no idea that there's a growth chart for little girls like my daughter and was ready to start one surgical procedure, as you know, lead to another, lead to another, lead to another. Side point, Anna's 19 now, turning 20 soon. She's never had any surgical procedures. The average kid with her diagnosis has had 13 by the time her age. So at that point in time, I just realized, like, oh my gosh, the specialists don't know. And it became a weight. It was a burden that I felt every day because, like, I have to get up. I have to figure it out. Like, who's going to figure it out? The specialist can't figure it out. And so that was where I had to figure it out, and so I got up early, 4 o'clock in the morning, started reading different, and at that point in time, there was not a lot, still not today, a lot about cerebral palsy. So I was looked at autism, looked at other neurodevelopmental things in kids, started studying gene-based therapies, nutritional therapies. But that was like what got me off course was necessity. Like, I had to figure it out. The system wouldn't listen to us. It was going to report us. The specialist didn't have the answers. And she was, at that point in time, she was probably 14 months old. Like, we had limited time. Like, I had to figure out fast. I couldn't figure out over 3 to 5 years and get another board. I had to figure out quickly. And so that was a fire that got me up every morning super early for over a decade.
I mean, it's an incredible story because I think perhaps for listeners not understanding the concept of failure to thrive, that's quite a significant diagnosis. It can apply to infants and children and adults. But the concept of a feeding tube, let's just unpack that for a second, just from the perspective of allowing the lay public to understand when we're putting a feeding tube in an infant or a child or an adult, there are long-term ramifications of that. It's a portal of potential infection. It's a portal into, as you mentioned, it would impede her ability to crawl, which would impede her ability to walk. It would impact her fine motor skills for chewing and swallowing, all of which are really important. When we talk about failure to thrive, just give us kind of a high-level perspective of what that represents.
It's hard to say. It's like a stamp. It's a mark. Mm-hmm. It's a mark, maybe. Say it's a mark that this child, we're not doing so hot.
Nope.
Like, failure to thrive kids literally struggle with absolutely everything. They struggle with neurological development. They struggle with basic math. They struggle with sensory integration. They struggle with feeding. Many times develop seizure disorders. So it's kind of like this mark where it's like, we're picking, it's almost like triage, in the ER. You're in the ER, triage, This person, okay, if we work really hard on them, they'll survive. Okay, this one, we do nothing, they'll be fine in 6 hours. Let's like give them some ice chips and stuff. This one's not going to make it. So we kind of like make them as comfortable as possible. It's like this triage mark. This one, not so much. They're not going to do so good.
Yeah,
but it was a weight. I mean, I'm not supposed to get emotional on these things, sorry. But it was a weight that it's a mark of this kid's not going to do well. And it impacts you in ways you can't imagine. I mean, you've worked with patients, but it's bad.
Well, and it makes it even more impactful when it's your child and it's someone that you are invested in love and care for and have a truly vested interest in ensuring that you do everything you can to support them and protect them. And I can imagine as a physician, it must have been even more challenging because you and Becky, she's also a healthcare provider, effectively being told that your advocacy of her is in some way in misalignment of her best interest. And yet, as her parents, you knew that there was more to this than putting a feeding tube in, and then compound that with the fact that you were reported to Child Protective Services, which, Child Protective Services is there for a reason. And certainly we could unpack what that represents. But I'm sure you probably were a little flummoxed when that happened, probably surprised as well.
For me, back then I was still in my bonehead days. I was in the military. I was very driven. It was more like an obstacle to get over. How do I fix this problem? I wasn't emotionally invested in my daughter at that point in time. It was like I had this responsibility, and falling in love with her was a process. It was part of the whole process of fighting for her. So, when it was happening, it was just, for me, I was like, okay, I had this child. These are things I need to do. And Becky took care of all, like she was the person that when the nurse came by to investigate us and interview us, she was interviewing her, not me. That she was taking care of all that stuff. But one thing that's interesting that because my wife, it was interesting. You're at Johns Hopkins and you can relate with this. Like her caseload in Florida was all these rare genetic disorders that I'd never heard of. Kids with craniofacial malabnormalities, weird genetic things I'd only heard of in medical school. And so part of her experience was a lot of these kids, the parents that fight for them, will go to institutions and they'll be gaslit. Mm-hmm. Mom's crazy, dad's crazy. Are they hurting this kid? Are they Munchausen's, which is people actually make their kids sick to get attention in the medical world, this weird thing. And some of them actually lose their kids for months, sometimes years, because the system is like, this is our thing. And so going into this, we had this, from Becky, I had this insight that we have to tread lightly, not engage the system too much, but engage it enough so that we are going in the right direction. So there's this thing in the back of our head, knowing that the system would push back, but it's different when it happens to you.
Yeah. Well, I mean, it's humbling. It's frustrating. It is, in many ways, I think it brings you to a point of humanity and allows you to see your patients so differently when you start to understand that everyone needs an advocate, and even more so for children and infants and toddlers. Let's kind of jump forward to how this process of caring for Anna, investing in advocacy for her, led you to this functional integrative approach to patients and their welfare. I think in a lot of ways, when I think about the limitations to conventional medicine, I feel like a functional integrative approach in many ways is trying to address this. I always say, if there's an emergency or an urgency, traditional allopathic medicine, there's nothing better. It's for most other things that there are limitations that maybe if people are healthy, they may not perceive there are limitations, but it's when you get caught up in yourself being sick or a loved one that all of a sudden you realize there's a lot of what we refer to as blind spots.
Yeah. So the question, because there's so many things you said to unpack.
Yeah. So you kind of, it's the limitations that you experienced in that traditional model as you kind of have gone through board education and, constant iterations on fine-tuning your skills and your ability to serve your patients. What are some of the things that stand out to you that are unique about this functional integrative approach that allow you to care for patients in a very different and unique way?
I'm super basic. I'm a super basic guy. I see it as...
He's really not.
When I was trying to determine if I was going to do general surgery or family medicine, my goal was I'm going to be a doctor in a mission hospital somewhere in the middle of nowhere. So literally you'll run hospitals with surgeons and family practice, and they run these hospitals in the middle of nowhere. So that was kind of where I was trying to figure out which one had the biggest scope, and I landed on family medicine. But as far as where the system you get in these places where you get your training. But for me, the thing is that I always wanted to keep on learning new procedures. So when I was in the military, we didn't have a dermatologist on our base, and I saw a patient with melanoma that couldn't get care. She couldn't see a dermatologist for 6 months. Like, that's a life or death time frame for someone with melanoma. So I got a textbook of dermatology, read it, signed up for courses at USF, and got some additional training in dermatology, and got good enough that I started managing my own skin cancer patients. If every year you add on a new skill set, the natural progression is we also didn't have for a while, just people got deployed. So we lost one internist that was doing cardiopulmonary testing. So I got trained on Holter monitor, got trained on stress tests, PFT testing, and started doing that for the base as well. And so just for me, keep on doing your stuff when you get out of your training. And that's what you do. And so with Anna, it became this thing, like I knew how to learn new things. I kept on learning how to to do new things. And when we got her, it was like, oh boy, like it's more than just me having my next intellectual curiosity. It's like, it really matters. And so how that is different is the natural progression, 80% of people who finish the training, they just read the journal articles they get. Mm-hmm. You're board certified in endocrinology, cardiology, family medicine. And so you get your journal every month that has the updates in it, and you keep updated in what an editorial board
decides is what's important.
Yeah. And so you keep up to date, but in a very limited sphere. And so a great example of this, when I was in the military, I had like 4 or 5 journals I'd read because they all had little things. One was the medical consultant. And it was like kind of like integrative. They talk about MRSA and skin infections and using vitamin A and Hibiclins and changing biofilms on the skin and a bunch of stuff. So I started seeing that in Florida with military people. Came to Virginia and actually mastered it pretty well. Came to Virginia right as MRSA was coming to Virginia. Mm-hmm. And people were like, what do you do with these abscesses, these boils? Well, I'd actually seen that when I was in Ecuador in a mission hospital. Young 20-some-year-old guys playing soccer get hit in the leg and get these actually muscle abscesses. And I also learned those on a nutritional basis. So all of a sudden I was like, cool, I already know how to take care of this. And y'all up here haven't seen it before. Well, that's weird. And so you do that over and over again. All of a sudden you kind of get this confidence. I think I can keep on doing this. It's just with Anna, she threw gas and lit the fire. And so it just supercharged everything. And so in the next 7 years, I added on 2 additional board certifications, a bunch of other certifications. And it's interesting how me doing that for her changed my practice in medicine. And it's affected thousands of people's lives who would, in Central Virginia, would have nowhere to go except for now our practice, which literally was built out of the fire and the struggle of taking care of my daughter.
Well, and I think, it's like that story is one that personally resonates with me, professionally resonates with me, because the desire to continue learning and being a lifelong learner is something irrespective of what industry you work in. We should all be improving upon our knowledge base. And as I jokingly say, know better, do better. Like, now we know better, so now we do better. But, for full transparency, as I always share when we record together, your trajectory of your education has impacted our family as well in such significant ways. So I feel so very grateful and appreciative that you have taken such a proactive approach to figuring out what other people maybe are not yet aware of, like the MRSA is a good example. For listeners, these are infections that generally are not treated with conventional antibiotic therapy. They sometimes can be more challenging. Now we've got way worse things than MRSA. It's like add on, times 10, all these other things. But let's talk a little bit about this kind of root cause approach that you utilize in functional integrative medicine. I know there are some unique things that I've learned through you about autoimmunity and gut and hypermobility. But from your perspective, when we're looking at this functional integrative approach, what are some of the foundational aspects of that when you're evaluating a patient, when you're talking to a new patient, to help them better understand their unique bioindividuality and to be able to serve them in a way that adds on to what a traditional lens would look at, but allows you to look a bit more deeply?
Okay. So I might get off track here, so you can help keep me on track here. Okay. So I'm going to answer that question from a 2-prong approach. The first prong is Willem Osler, right? Actually, you might know who that guy was.
I do. He's a big deal in Hopkins.
A big deal in Hopkins, yeah. So we learned about him in school. And the idea is that 80% of all diagnoses can be made by history and physical. You can learn, where did you grow up? What did your father do? Your family environment, what you ate as a kid growing up, trauma, life experience, where you live now. Like 80% of the diagnosis can be determined by history and physical alone. I was taught that in medical school. But what's happened is through technology, now we've become, it's this thing called, I learned at a trauma conference, vomit syndrome. We're victims of modern imaging techniques.
Vomit, that's a new acronym.
It was actually a trauma conference I went to during when I was in the military, because we had to do, chemical, medical, biological, chemical warfare stuff. But it's interesting. And they're pointing, this was when the residency thing was changing to the 80 hours. And so they're like, how are we going to have surgeons still learn liver repair in a regular surgery? It was a lot of things, but the gist is that at that point in time, they were already saying we are becoming victims of technology. So I did a test, I did an imaging thing. There's nothing there. Well, William Osler had said, ask the patient will tell you. In functional medicine, one of the main parts of it is going back to the patient will tell you what's going on.
Yeah.
Did you have personal trauma? What did you eat growing up? Did you live near a factory? Are you from Annapolis? Are you from Long Island? Did you grow up, if you're from Phoenix, where all the fires, when they have the fires every summer, like all these small environmental things can impact the health of the people who live there. So that's one aspect of functional med that's being lost. We kind of hear about it in medical school, but no one does a 2-hour intake.
They don't have time.
Yeah, we do it, 2.5 hours. But so it's just almost reminding us of the ancient wisdom that patients, the patient will eventually declare themselves, right? If you have the time, you make the effort, you ask the questions, you will eventually tell me what's going on. Fancy technology just helps clarify that. And that's something I feel like in the biohacking, optimal wellness world is absolutely forgotten. It's now, I got a new peptide, I got a new stem cell, I got a new thing. This will fix you. It's like, no one's spending 2.5, 3 hours to talk to the patients. And then the longitudinal learning nuances, which, we can talk about more and more so, but that informs what you do with the patient. So part of integrative functional medicine is just expanding on old wisdom, old knowledge. And there's the new stuff, which is systems biology, which is, there's this thing called the gastroneuroimmunoendocrinology. Fancy word. Your gut affects your hormones, affects your nervous system, affects everything about you. And so it's interesting how you can go to institutions and get a PhD in this, but then you talk to specialists and like, I'm just the gut, I'm just the neurologist, I'm just the cardiologist. Yeah, salad. And so part of what functional medicine does, it says, you have your old toolkit, keep it, because if someone has appendicitis, you got to fix it. If you don't fix it, you might die, right? You got to keep your old toolkit. We don't throw it away, but if someone, after you've had your heart attack or stroke, can we make your calcium score go down? Can we actually make your LP(a) lower? I've lowered people's LP(a). Traditional medicine says you do that with a medication called a PCSK9 inhibitor, right?
Yep, for Repatha.
Yep, one of the many ones, right? That's a part of functional medicine is this root cause, looking how does everything relate with everything else? You've got gut issues, and you've got brain fog, and you have joint aches and pains. Well, we know from the association of your immune system, 80% of your immune system is in your gut. And we know with neurotransmitters, 75% of all neurotransmitters are made in your gut, 90% of serotonin, 50% of dopamine. All of a sudden, if you have psychiatric issues, if you have an inflammatory condition, maybe, just maybe, this is actually an expression of your gut. And so what functional medicine does is looks at the associations. There's like system 1, which is your adrenal gland, your thyroid gland, your pancreas. The system 2, which is your gut, your immune, your brain. There's system 3, which is your cardiopulmonary neurovascular, which is a fancy way of saying arteries and nerves that connect your heart and your lungs and how they affect everything else. There's your detox system, liver, lymph, kidney, lymphatics. And then the last one is your hormones, sex hormones. And so all of a sudden, you think systematically, someone with heart disease might have a hormonal issue, because we now know females as well as males, your hormones being off increase your risk for heart disease. Or maybe it could be a thyroid issue. Mm-hmm. If your thyroid's low, increases risk for heart disease. It's not just you have high cholesterol, take a statin kind of thing. And so looking at people as a complete whole, looking at your history, looking at your environment, and combine with a systems approach. And then you basically, what I've done is just fill that in with deeper science, lipid medicine, mast cell stuff. I mean, hypermobility is one of the things it's one of my things I love talking about. And the thing is, every 3, 6, 9 months, you add new skills, new tools to your toolkit. And all of a sudden, your toolbox is this massive thing. And everybody, and this, I keep on rambling, but this is a mantra I say when I go to work every morning. I ask to see what can't be seen, hear what can't be heard, and diagnose what can't be diagnosed. I do that every morning when I drive to work. And it's interesting how, like, I will sometimes read an article about, we're talking about, IV phosphatidylcholine before we start, something will pop up. And it's like, wait a second. I just read about that. Someone comes in, I can help them with that. And that happens so much. It kind of keeps me on my game. I can't stop learning and stop reading because I don't know what new person is going to come in my clinic. And if I don't have the knowledge to help them now, I need to be learning so that whatever that gap is, I can fill it in. And that's the practice. It's good medicine. It's the practice of medicine. We call it functional, integrative, translational, biologic, personalized, whatever you want to call it. But I just think it's just good. It's good medicine.
Well, I think that every person listening deserves to have that. That is something that has been so affirmed for me because the traditional model in many ways is not meeting people's needs. And I think that certainly, I hear it when people say like, I'm paying a lot for insurance and then, trying to figure out ways to, budget for additional care. But, I always use my husband as a good example. Last year, listeners know that he had a healthcare hiccup. Initially, I was convinced he had lymphoma. Thank God he didn't have lymphoma, but through a series of hospitalizations, surgeries, and biopsies, we found out he had tuberculosis. And the first person who said to me, Cynthia, there's something deeper going on, was not the pulmonologist, was not the surgeon. It was you, because you were thinking really broadly. And I was too immersed in everything that was happening, is what happens even to good clinicians, is that you're just like, I can't see the forest through the trees because I'm focused on a sick spouse. And so I think that my hope is that every person listening at some point will have a clinician that they can work with that thinks that way, because everyone deserves that level of care. And that's the unfortunate thing. There's not enough of you to be able to support everyone, but I think things are improving. Like clearly more and more people, more and more clinicians are going to get functional integrative training because they're seeing the limitations in the current medical model. What do you think is one of the ways that we as a society can better support the education and the advocacy for clinicians being able to utilize this kind of training and do so effectively?
I think ultimately, everybody who goes into healthcare goes into it to help people. They don't go into it because these days they don't go into it for money because you can make more money just doing something totally different. They go in because they want to better the world. They want to help. They want to help the fellow person. They want to make the world a better place. And I think the best thing that our system can do is just let your winners run. Leave them alone. Remove restrictions. Remove restrictions on having a membership model. Like I had to spend $15,000 to consult a fancy lawyer to get paperwork that enables me to have a membership model. Direct primary care. Like there's so many limitations, malpractice, even insurance. It's like, oh, that's not approved by the FDA. Your vitamin D is still controversial according to the Institute of Medicine for whether we need that. And it's like, really? Like the literature's decades old. I've known about it for 20 years. And so everybody has a different perspective on things. Should the government pass new laws? Should we have new legislation? Should we have more coverage? And my response is that's not worked in the past. We have enough people in our country who want to do good, grab the education, release the hounds, let them go. And all you got to do to release the hounds is remove the barrier. And so my thing, I think education, I think what you do is ridiculously important, educate people, because the only way we're going to release all those hounds is if people demand it. If people say, no, I want my doctor to have 45 minutes. I want them to have an hour with me. Why can't I use your insurance? And if I want to spend an hour with you, why can't I just charge you a little extra?
Yeah.
Why do I have to create this ridiculous model? Or if I don't want to accept insurance at all, Medicare says, well, if you go bare, you don't take us, you can't sign back up for 3 years.
Yep. It's a
big risk. So now you're saying, oh my gosh, if I opt out of Medicare, I can't go back in for 3 years. Like, why is that? It's a scare tactic to keep people in the system. So my personal philosophy is we just need people to demand more. Let's go start at the local level. A lot of states determine how every state has its own, board certification and their own license. But ultimately, the reason things are changing so quickly now is because more and more people are learning about it and they're demanding it. And so I'm a bottom-up kind of guy. I think you just need to reduce limitations on physicians and providers. You need to let us run, not limit us to only things that the FDA says we can do. It's really funny. I remember reading this in one of my journal articles not too long ago. 60% of medications used in the pediatric world are off-label.
Yep.
And I'm like, then why, when I want to use vitamin D and get your level to 100 because you've had breast cancer, and Dr. Paul Merrick wrote this amazing book called Cancer Care that has 1,500 citations in it. It's almost 50 pages of citations. I was actually reading this one things I read in the last month, which is
just for fun,
just for kicks, because I got nothing else to do besides raise my kids and have a farm, and But it was interesting in that they had multiple citations. It's a reason I say how many citations is like he at one point in time was the most published, critical care specialist in I think in the world, but it's crazy. But up to 130, the risk for if you have breast cancer, the risk for metastasis and recurrence is equivalent to being on a aromatase inhibitor.
Wow.
So it's like, so you have breast cancer and give this medication, they'll put you in medical menopause, you'll feel miserable, brain fog, you ache, or I can get your vitamin D level to 130. And if you're worried about toxicity, I'll check a PTH and calcium. That seems like a no-brainer. But if you mention that to other people, like, oh, where's the literature? It's not evidence-based. I'm like, just read this book. There's 1,500 citations. It's like,
It's completely reasonable. And I think that's they talk about Flexnerism and how that has influenced medicine. And I'll use a good example, and I'm not going to name names, but the utilization of GLP-1s as a good example. Yes, they came into their existence to help people with obesity and people who have comorbidities that are obese or overweight. I think there are so many people now that are utilizing these drugs off-label, microdose, that it's improving their autoimmune conditions. It's helping with inflammation. There's all these benefits. And yet I sometimes will see, I know they're well-meaning individuals. I won't even say like what their background is, but these are licensed medical people. They get very kerfuffled about utilizing, whether it's a GLP-1 or another drug, utilizing it like, oh, where's the research? What's been done? And I'm like, I think we're forgetting that one of the ways that we bring drugs to common acceptance and trials and being able to get to a point where we can eventually develop a randomized control trial is people using things off-label. And so I think in many ways, this is one current issue that I see kind of personally as well as professionally, that there's a lot of, how do I say this? There's a lot of arguing on social media. And let me be clear, it's not like it's a layman that's suggesting this. It's healthcare professionals saying, I'm seeing benefits in my patients, and this is why I'm now utilizing this. And then there are the Flexnerism and the Flexner Report. I know we've talked about it multiple times on the podcast, but the development of the Flexner Report in the 1920s kind of revolutionized not only the way medical education was taught, but it also impacted the siloed kind of care that we have in medicine that's very driven by diagnosis and not the root cause approach, but diagnosis-driven, medication-driven, screening-driven, which is both good and bad. Do you have thoughts around that? You don't necessarily have to speak to the GLP-1 piece, but...
I could talk about that too. So.
Yeah.
But I try to think of things, I'm a simple guy. I try to think things basically like, I look at it as academic versus practical. Like
Ivory Tower.
Yes. It's like the academic is great for getting your education. Like I went to university, I went to medical school. I've got 5 degrees of different things. I went to seminary. I've done a lot of things, right? But that gives you the tools. How does that work in the real world? And that's the practice. Mm-hmm. And this happens if you're an engineer. It happens if you're an accountant. It happens with any technical job of expertise, that you have to learn the deep science information. But how's it work in the real world? It's totally different. And that's where clinicians who have been doing it for 30, 40, 50 years have experience. They're like, this is how this really works in the real world. And that's where I think the academic side, ivory tower side, they forget that the ultimate, in my mind, the ultimate science is the practice of medicine, because you're taking astrophysics, you're taking the issue with astronomy, and you're taking environmental medicine. You're taking, if you could talk about the Earth's magma and how it flows under the core of the Earth, creating electromagnetic fields called flux fields that affect human health. Like, it gets really, really complicated, right? But then people use that information and use pulsed electromagnetic field devices to modify our physiology, and it just kind of makes sense. And that's what the practice of medicine does. GLP-1s are a great example. It was really funny. One of our friends and colleagues asked me about GLP-1s, and put things in perspective. Also had a clinical research company for almost 15 years, supervised over 70 clinical trials, and personally started using GLP-1s in 2006 with Byetta, then Victoza. Yeah. So I've been using them for a long, long time. And this friend and colleague was like, "Hey, have you heard about microdosing?" And I'm like, and this was November of a year ago. So yeah, and I'm like, what? Whatever. I was very polite and nice to her. And then 3 months later, in my MCAS group with Dr. Afrin, who's like the top MCAS guy in the universe, he's brilliant. A group of really brilliant people taking care of complicated patients. People were in there. I've been microdosing with my MCAS people. They're having less food sensitivities, less chemical sensitivities. Their dysautonomia is getting, their POTS is getting better. And then in this group, they're like, everybody's brains are, how would that happen? And so people are saying maybe it's because it's affecting mast cells, stabilizing mast cells, which is, one of the things. GLP-1s are anti-inflammatories.
Yep.
Have to remind people it's now FDA approved for cardiovascular risk reduction, renal protection in diabetics, treatment of sleep apnea, to diabetic medication. And I was listening to and I'm not a big pharma guy, like, I use herbs and I use everything, like everything. Like,
you're fully open-minded.
If it works and there's data behind it, let's do it. And that can also mean if a culture's done something for 4,000 years, people forget the first stool transplant, fecal microbial transplant, occurred about 4,000 years ago. That was actually warm camel dung to treat cholera. Okay.
Wow.
So the idea of, oh my gosh, people have been doing this stuff for a long time. And so the point is that this group, we're seeing people using it and having really great results. Well, I heard that, and it was funny because it was popping up in social media before me as a doctor heard about it in my little group. So I started trying it with patients, right? And now I'm like, I love it. It works amazing. And people in the community are like, what? It's like, you have to have, that's the reason why I'm in so many different groups. With, like, I'm not on social media groups. I find these groups of really smart people. And my thing I tell my patients is that I find the smartest person I can. I'm a leech. I find them. Yeah, I grab onto them. I read all their textbooks. I read their stuff. I take their courses. I just finished this past weekend a phosphorylcholine certification course.
Of course you did, in your spare time.
You know what? It's again, you got to help people, right? And then I take all the knowledge out. I fall off. I process it. How do I implement this? And sometimes it's just cool data points. And I put it in my files. I have like a library on my computer of like thousands of files. And then I find the next smart person. And the caveat to what you said previously, the idea popped in my head. It's amazing. On this journey, one thing I've found that's amazing, there's so many smart people out there. Patricia King with lipid medicine, been doing it for 40 years. You're Afrin with mast cell stuff, been doing this for 20 plus years. Like, there's so many people that have figured things out decades ago that there's so much amazing information out there to be found to help people. You just got to look for it. And so it's one of those things that when you realize that, you're like, oh my gosh, I have people I can't help. I need to learn more. That's really kind of interesting.
No, it's inspiring. It's something that I respect about you enormously. That's why we are both doing Pam Smith's program, because I was like, oh, if Aaron's doing it, then I need to be doing it because I can learn just as much as well. One of the things about kind of traditional allopathic medicine, you look at things that create this kind of sick care model. And again, I know I'm poking a bear, and this is not out of a lack of respect for what colleagues are doing. I just think there's limitations. What are some of the subtle ways that we unknowingly are harming our patients? You talk about it in the book. I think this is worth kind of addressing because I think some of these, perhaps the lay public might be surprising.
I could go anywhere with that statement.
Yeah, I would say maybe something that stood out to me when I was reading your book was, number one, normalization of procedures, surgery, and hospitalizations as being one, and maybe one or two others. I just think we've gotten very normalized. Like I will give you an example. My father, before his death, wore it like a badge of honor that he got a colonoscopy every 2 years. And I used to sometimes say, Dad, he was close to 80 years old. I was like, every time you go under anesthesia, that is a risk as you get older. You have to understand like cost benefit. Is it worth it to go through another screening procedure that if you were to get a precancerous polyp and it wasn't removed, this is something you could probably go 5 years and you would be fine. But I use that as an example that we have normalized a significant amount of screening, overdiagnosis, hospitalization, and surgeries as being normal.
Yeah. So I'm not sure if you want me to go this pathway with that, but this is where my mind goes, is the idea of the blind spots, and one of those being medical error. When I was in medical school, I was told that iatrogenesis, which is things we do, was the 5th most common cause of death in our country. Martin McCary, who I keep on going back to this whole John Hopkins thing, but he was there for years. I know, like, you're loving this, right? Like,
no. What's funny is he was supposed to be a guest on the podcast, and then the administration changed, and all of a sudden availability was
zero. Yeah. So, so wrote an article about medical error. Is this the 3rd leading cause of death in our country? As an academic at one of the most prestigious institutions in the world, definitely in our country, part of science is I have a question, I have a thesis. Okay, I agree, I disagree. Let's make a study. Let's study this. Let's follow it. Well, he couldn't get it published in any American journals. So we had to go to the British Medical Journal, where they actually this might be a problem, because in America, the editorial boards we talk about did not see medical error as a significant concern. So the question is, well, where is he getting his data from? He was getting his data from Medicare registries. So that's pretty legit. The NIH, big organizations do this. But my question to his question was, well, if this is Medicare registries, like, is it number 2 or number 1? Because you're missing out pediatric stuff. You're missing out Medicaid. You're missing out on people on insurance. You're missing out on a bunch of stuff. So my question is, oh my gosh, we have to study this, because maybe it's not the 3rd most common cause of death in our country. Maybe it's number 2 or number 1. But in our system, the editorial boards of New England Journal, JAMA, et cetera, like, that's not
bad for business.
It's not noteworthy. They have to go overseas, which is one of the things I do a lot, is look at information overseas, study physicians, read journals, articles, researchers overseas. I've had to take my daughter out of the country before for her to get care. That's a big blind spot. And engaging in that, and this is, the Hippocratic Oath. Part of the Hippocratic Oath was enter no house for harm, only for good. And they realized that seeing doctors actually can be dangerous. When I was in Ecuador, we had a young guy come see us. He had had an infection for weeks, and the mom eventually brought him to the hospital, and he had meningitis. So we had to admit him to the hospital. Well, the mother in that culture, in that indigenous culture in Ecuador, if you get admitted to the hospital, it means you're going to die. So she withheld him going to the hospital with the understanding that the hospital's a dangerous place. And when we admitted him, she was like, this means my son's going to die. And you can hear her wailing, like, down the hallways. It was this gut-wrenching, like, it was crazy. And he left a week later with his mom. But it was one of those things that, like, in that culture, they respected. The hospitals are dangerous. In our system, we're like, get your procedures, take your medications, take your stuff. And it's like, when my dad had called me when I was in the military, hey, Aaron, I'm mowing the yard, my reflux is acting up. My dad was an ex-Marine, by the way. I'm sorry. I apologize. He's still a Marine at 80.
See, I was just saying, that never goes away.
There are no such thing, right? I mow the yard, I get my reflux acts up, my heartburn acts up. Okay, well, what happens when you rest? It goes away. If you start mowing the yard again, what happens? It pops back up. Can you get that looked at today? Went to his doctor, had an EKG, had a stent put in that night for a 99% blockage. You've probably heard this story before. We need that. In our country is the best in the world. Like, if right now I need to get a life-saving stent put in, I need to get thrombotic therapy for a clot, I can get done 3 hours right here in good old-fashioned Midlothian. with my local community hospital, St. Francis. I don't have to, that's amazing. But for all this other stuff, chronic care stuff, engaging the system has risks. And I think people don't appreciate those. And that's where I think working with a provider, working with someone who respects our system is amazing in some things. And some things our system potentially is the number 3, maybe higher cause of death in our country. And I think that why can't we talk about both those? Why can't we have both? And it's weird how everything's become politicized and everything's become like, oh, you're an anti-medicine guy. I'm like, no, I've got 3 board certifications. Like I've got, I'm a medical doctor. I'm pretty legit. Like I'm not anti-science. I'm pro-human. I'm pro-people. I'm pro-patient. And that trumps everything.
Well, and that's the distinction, is that sometimes when we are in the system, we forget we are looking at people. And those people have vested interest in making sure they get to go home. And I think the other piece of it is, and I would be the first person to say this, my husband got mediocre care in one hospital, better care in another, but we could make an argument given the fact he had tuberculosis and was on a transplant service, which that's a whole separate conversation. But I think in many ways, for each and every one of us, we want to know we've got a quarterback. We want to know we have a healthcare provider that is looking out for our best interests so that we can navigate the system. And I say that objectively, but also personally, having been on the other side last year, when sometimes you lose objectivity because you're so caught up in the personalization of what's happening to your loved one.
There's a reason why I can't see my wife.
Yeah.
Because it's too close.
Yeah. No. My husband kept saying, I don't need a primary care provider. I was like, yes, you do, because I can't be your primary care provider. What about overdiagnosis? So I mentioned the screening piece. And yes, it's important for us to, whether it's getting a colonoscopy or mammography or whatever it is that we're supposed to be looking for, how does overdiagnosis complicate this system? Like, where is the happy medium of figuring out what is appropriate screening for that patient as opposed to applying it to everyone in a society?
Yeah, well, the overdiagnosis thing, it's tricky because it's how we get paid. And every diagnosis, every ICD-10 code is weighted. When I put them in the EMR, I'll get a 0.3, I'll get a 1, I'll get a 1 point, I'll get a weight. And that weight means if I put a billing code with it, like I'm justifying my
existence.
Existence, pretty much it. My RVU value, because it's not based on how many patients you see, it's how many RVUs. So you have this system that economically, the more diagnoses, the better. I used to work in the hospital for 15 years, and if someone gets admitted for, UTI, it's like, no, Dr. Hartman, you want urosepsis.
Yep.
And change the code. And let's do a 23-hour admit because this person can actually get out.
Yep.
And 24 or 5, and you actually will get more for a 23-hour admit. So I'm like, and there's specialized nurses who literally, that's all they do in the hospital. Yep. And I'm just trying to take care of people. So I'm like, just put in my chart, take care of it. I don't, whatever, And, but the system's actually driven by that. And so you might have someone come in with a list of 30 diagnoses. And sometimes these lists are like how can one person have this much stuff? But then when you start thinking about things functionally, you're like, you've got high blood pressure, you're diabetic, you have high cholesterol, you have osteoporosis, and you got gout, and you've got kidney stones. It's like, those all can kind of fall under metabolic syndrome, which is a mitochondrial issue. So what's your nutritional status? How many nutritional labs have you had? Fatty acid labs have you had? The answer is none.
Yeah.
And so all of a sudden, these 5 or 6 diagnoses, are there some basic foundational things? What's the code for metabolic? I'm sure there's a code, but what's the code for this over here that pays? And the answer is not really a good one. Then what's the specialist? I have a specialist for blood pressure and cholesterol and gout and rheumatoid and all these things. But what's the specialist for this? And that's where it's extra training, which, by the way, is not recognized by insurance companies. So you won't get paid for anything you do with that board certification or extra training. And if you have a malpractice thing and go before, the State Board of Medicine, they'll be like, well, what approved diagnoses? And when people ask you these questions, all of a sudden the answer is like, I'm just doing what I have these conversations in my head sometimes. And like with the cardiometabolic stuff, it's like, well, Dr. Mark Houston, who wrote the textbook of vascular medicine, vascular biology, I mean, he's at Vanderbilt at the, that's what he does, but in court, does that hold up? No, and that's that part of the training. It's so amazing is like the people we learned from, Dr. Fasciano, who discovered how celiac disease, discovered zonulin. He's up at...
people thought he was crazy.
People thought, well, even Dr. Marshall, the whole idea of, this is a great example. Dr. Marshall, blind. So it's a brilliant segue. So this is a GI doctor in Australia who said one day, he's like, I think maybe bacteria might cause stomach ulcers. You're crazy. There's no way. Ostracized. So what did this guy do? He found this thing, he cultured it, and we scoped himself first, which is,
impressive.
I know. They swallowed it, started feeling sick, scoped himself again, stomach ulcers, gave himself an antibiotic, and how many years later, got the Nobel Prize. And now we know that stomach ulcers are actually caused by a bacteria, Helicobacter pylori, a surgical procedure, a vagotomy, which used to be done often. We'd send patients to Hopkins because they had that big center there. We specialize in doing that thing. No one knows how to do it anymore because they don't do it anymore. And it's like, but he was ostracized, he was ridiculed, and now like everybody knows that, there's a bacteria that causes this. And so that happens all the time. It's happening now. And so part of this whole thing is like, when I see people, I'm like, what's being missed? What's the blind spot? What is the thing that 20 years from now, Alan will be like, oh my gosh, I can't believe. And it's amazing if you practice like that and think like that, you'll see so much stuff.
Yeah. And I think you brought up a really good point that many healthcare professionals have a fear of being sued. And that oftentimes is what drives over screening, over diagnosis, too many procedures. And you talk about in the book, the liability trap.
Yeah.
Help listeners understand what it is that is, how that is affecting medicine significantly and profoundly. I know in cardiology, when I had students with me, I used to tell them, especially if we were in clinic, I was like, what are the 3 things if someone comes in with chest pain that you have to rule out so you can comfortably go home and sleep at night? And we would talk about this because I would say, if you miss one of these, the patient will die. And that is at least how I would encourage my students to be thinking kind of proactively. But in many ways, it's that kind of mindset that in many ways is encumbering the system and making it challenging to practice within.
Well, I learned in 1996 that every patient is a potential lawsuit.
Yep.
And so back when I was doing my ER rotation, I had a young lady come in with abdominal pain. And I went and pushed on her. And in family medicine, we learned how to do a clinical exam. We learned you can, if you push it, no rebound, there's no decrossivity sign, no fever, it's not appendicitis. We wouldn't, so I go present to the ER doctor and he's like, so are you going to do a CAT scan? Like, well, why would I do a CAT scan? Like, she's, so, okay, student, Dr. Hartman, we're in court now, and I'm the judge.
Yeah.
This patient, young lady, was concerned enough about her health to come to your institution at a Friday night at 11 o'clock for her abdominal pain. And you didn't order any testing. You didn't do a CAT scan. You didn't do an ultrasound. Why? Then you're like, dot. Then you're like, okay, I'll go in and get a CAT scan. Feels normal. She went home. But why was he framing it like that? Because the medical legal. And so there's that aspect. There's also the aspect that if you come to me, I give you medication. Like, how many physicians have been sued for giving someone Vioxx and having a heart attack? The physicians weren't sued for that. How many physicians have been sued for giving patients birth control pills to get a clot, to get DBTs? You don't, because the liability is off. But if you don't give someone a medication, you don't treat something, and they have a bad outcome, you get sued. And so all of a sudden, there's this impetus to over-test, to not miss stuff, and over-diagnose. And if you go get a colonoscopy, it's accepted, and you have a punctured bowel, well, that's an accepted risk. If I miss a colon cancer, that's an acceptable risk.
Let's make sure we at least touch on the triangle of health for you. When you're talking to your patients, when you're talking about options of kind of an approach to lifestyle as medicine, Let's unpack this because I think this is applicable for most people listening. These are things that are very important that do have a large impact on your health.
So it's something I developed because you'd see patients, complicated issues come to you, and you create this massive protocol. It's complicated. People get confused, right? So I was trying to think, and then you kind of walk this process and people get stuck. Like, I'm not healing. Like, I'm a little better. I'm 20% better. My A1C is a little better. I've lost a little weight. Where are people getting stuck? Where are people's leverage points? Where are the places that if I've focused on them and just really hammered them, that I'll get 80% of the outcomes. Okay. Or people are going through the healing process, they get stuck and they don't go past that. And that's basically your gut, stress, and sleep. And so your gut is this big world. Yes, it includes fancy data and PCR and microbiome testing, all that kind of stuff, but gut's also like what you eat, which can be really super complicated, or it can be simply just eat real food, unprocessed, mostly plants, however you want to say that. But gut health is a lot of different things. Stress is another thing. So there's stress, like, hey, I'm stressed, we're all stressed, et cetera, et cetera. But I look at it as different levels of trauma. Your big T trauma, little T trauma. So if you had a MACE event, major adverse childhood event, that's going to set up your nervous system and your immune system. The whole psycho, neuro, immuno, gastroendocrinology thing. Well, your gut, so your brain, controls all those fancy kind of things. Or it could be the trauma or stress of a kid with health issues, a special needs kid. I feel like every mom of a kid with special needs I've seen has trauma from that kid.
Of course.
Multiple almost dying, multiple ER visits. And I also see this with people caretaking for an adult parent with Alzheimer's, dementia. And so looking at how that impacts someone's health is huge. And there's so much you can do for that. And then sleep. It's when your body heals. It's when it repairs. There's a epidemic of insomnia, maybe not insomnia, but sleep deficiency in our country. The average American is getting like 6.5 hours of sleep a night. And when you're an adult, you need 8 hours. That's only like 2 hours. But if you're a kid in first grade who needs 10 to 12, and you're like getting the school bus, getting to school, then all of a sudden it's like kids are getting sleep deprivation from a young age. And so those are three things I found that have a massive impact on people's health, that if we get those right, a lot of our things will fall into place.
I'd love for you to just wrap the conversation up today addressing the trauma piece, because I've learned a lot through you. And I think that there are a lot of women who perhaps very high functioning, they maybe didn't experience big T trauma, which is what I was taught, that's trauma. So I was like, I haven't had any trauma in my life. I think for a lot of individuals, when they start to look at, maybe their internist, their primary care provider is encouraging them to walk through the adverse childhood event scoring, which you can get online, which is accessible to everyone. And they find out, oh, yeah, I have experienced quite a bit of adverse childhood effects. From your perspective, when you're doing these deep dives, you're spending an hour and a half, 2+ hours onboarding new patients, or you're looking at middle-aged women who are coming in who are perhaps struggling with a multiplicity of constellation of symptoms that so many of us do. What is your kind of approach that you take around these kinds of conversations? Because I would imagine for some people, they may not be ready for those conversations.
Most people, as of now that I meet, aren't quite ready for the conversation, because you're a strong person, you're a strong woman. You can do it all. You're a professional. You can run 3 businesses and have a family and navigate all this. What do you mean this event that happened to me 20 years ago? Like, no way. What do you mean that the stress of this kid who almost died 2 years ago? What do you mean? And so part of it is just like, I collect the history and I write down the things that mean things for me. And as you know, when I look at people's charts, I can scan on the left side and I'll sometimes pop down, jog my memory, what happened to you when you were a kid, right? And we'll go through the process. And what tends to happen is you get, and sometimes it's 3 months in, sometimes it's 6 months in, sometimes it's 3 years in, 4 years in, where someone's like, I think, we've been doing this. There's no mold, there's no Lyme, my gut's better. My hormones my hormones look okay on lab tests. I still feel horrible, but my labs look great. My cortisol is still jacked up. And like, is there unresolved trauma? And I had one patient, it was really interesting. She was in her 80s. And I've been talking to her, and she had issues with her mom. Mom was dead. And so it was funny. I was back, for some reason, at that point in time, I was watching Dr. Phil for a little bit. So I had a Dr. Phil moment there. And I said, what you need to do is her mom was buried in Florida. And you get in your car, drive to Florida, go to your mother's grave. And maybe Dr. Phil wouldn't say all this, but that was my interpretation in my younger years. You need to curse at your mother, tell her everything she did wrong. You need to forgive her. And she had no problem with the first two.
Yeah.
It was a forgiveness that she was like, no, I can't do that. I can't do that. So 8 months later, I saw her, and she came in, and she was totally different. She was bright. She was happy. She was a different person. She's like, Dr. Hartman, I did it. And what she told me she did, I forgave my mom.
Yeah.
She didn't tell me she went there and cursed her and told her that. She's like, I forgave her. And she's in the mid 80s. I think she was 82 or 83 at that point in time. And so it's amazing how just a difficult childhood and how you could hold that for your entire life. And so it could be forgiveness. It could be meditation. It could be prayer. It could be EMDR. It could be tapping. It could be somatic work. And I have like this handout that I've probably sent you before that has all these things on there. It's like a buffet of what resonates with you. And some people, prayer will resonate with them. Some people like, I am so wired. I need technology. And so maybe you do neurobiofeedback. Maybe you do tapping, EMDR. There's so many things that can help just calm and rewire your brain, but it becomes a big deal. It's crazy, crazy common.
Well, and it's interesting that the power of forgiveness is not about them. It's about you. I think for so many people, it is so important to give yourself that gift. Like listeners know the whole story with a lot of the things about my father, but the reason why I was at peace when he died was because I had done so much work to forgive him. And in the last moments of his life, I think in many ways, it was some type of an understanding between us both where we were like, there's been a lot that was not ideal, but in this moment, I'm doing everything I can to forgive you and send you to heaven or wherever else you're going, and do so in a way where, you're at peace and I'm at peace.
Yeah, but it's a big thing. It's common, and it happens at every age. And so if someone's listening to this and they're stuck in their healing process and they're like, I've had my hormones checked and I can't ever get them right. I can't ever get my thyroid right. My guts all is off. Like I've been all the people, even the functional, and this is something that a lot of the functional people miss, because it requires a different level of intimacy with your patient.
Correct.
And also almost vulnerability with a doctor, because it's not as scientific. It's not as fancy.
It's feelings.
It's not as like, I read this new article and 5 new textbooks thing. It's super basic. And so for many reasons, it's something we neglect. And if your body's going to self-heal and self-repair, if you don't get your nervous system, your spirit, soul, body, like aligned, which I know sounds, I can't believe I'm saying that, sounds so woo-woo. It's going to affect how your body heals.
Absolutely. And it's interesting. Last night I was having a conversation with a fellow nurse practitioner, Heather Quails, and we were talking about how in many ways we're so grateful that perimenopause, menopause is having this incredible moment. There's a lot of awareness, a lot of money being spent on better understanding women at this time in their lives. But I said we are oversimplifying things by just making it about replenishing hormones. And to your point, it is a lot harder to deal with the internal work than it is to just slap a patch on, but equally important. Please let listeners know how to connect with you outside the podcast, how to get access to your new book. There's a ton of content in this new book. We touched on about 1/10 of it. Thank you for writing this. I really enjoyed reading it. I know it's going to help a lot of people.
People want to know more about me. There's aaronhartmanmd.com, which is my website. And that takes people to my website for my practice, my podcast, my blogs. I'm really big in education. So we have over 300 blogs. We have just so much information. And as far as the book, it's uncurablebook.com. And it's basically my story of interacting with the healthcare system, what happened with Anna, and like my development as a person, how she's progressed. Spoiler alert, she's turning 20 next year and will be probably my first child moving out of the house.
Wow. So
she's come a long way. And it's just, and the point of the book in my mind is like, if this little girl who was exposed to crystal meth has stroke before she was born functionally blind, if she can do it, you can do it too. So part of it's like cool stories, her story, but also it's meant to be an inspiration to people that, you know what, you can do this too. It's a journey, but you can do it.
Well, when I read the book, I wanted to text you, but I didn't want to text you and Becky on a weekend. But I was like, what an incredible story. I don't think I fully appreciated and understood the journey that you all have been on. But thank you for what you do.
Thanks a lot. Appreciate it.
You're welcome.